So welcome again to First Aid AMC MCQ. And we are going to start our today's session. As you know that this is a free session and we are going to discuss on question solvation, tips and tricks. So tonight we are going to discuss mainly on how you should prepare yourself for your MCQ exam. So remember the psychiatry session that we have taken, that was actually the theory session. And tonight we are going to talk about like how to go into the question and how to find out the clues in a particular question, and based on that clue, how we can solve a question and get our answers correct. And that's the vital part of your MCQ exam, because you need to make your questions correct in the exam to pass it, right? So let's start it. No, Dr. Kashan, you can't record it. It's only recordable from my side. So I'm going to record it and you will be able to hear the recordings in the YouTube after the class. Okay. Now, those of you are in the Facebook, if you guys don't understand anything, please feel free to write it in the comment box and I'll be able to look into your questions on and off and then answer your questions. Okay. But obviously, like it's more easier to talk in the Zoom session. And if you have any problem, those of you in the Zoom, just write it in the chat box and I'll be able to see that what's your question and answer it accordingly. All right. So let's start. And before we start, just to catch on the previous session, remember we talked about how MCQ exam usually happens, what's the criteria and everything. So obviously you should remember that your MCQ exam is 150 questions, all right? So it's a computer-based questions. That means you have to be on a computer to appear the test. Now, in our software, like those of you has already been joined the course, I can see a lot of you have already joined. And also like those who will join in our upcoming new session starting from day after tomorrow, day after today, I think. So 31st of August, right? So for those of you, you will be able to see in our software the questions and mock test. So that's exactly a replica of how MCQ exams will also happen. So just go through those things, that how to appear in the exam, what are the things that you have to do. It's everything we will discuss again and again throughout our 5-month session. All right. Now tonight, it's not a part of 5 months course. It's just a free class. We just want to discuss about the initial part of question solvation, because throughout the 5 months course, we'll be doing this question solvation with you, and like on and off, like how to solve one questions. We will be doing subjective question solvation. We will be doing lots of question solvation throughout the course. And there are lots of questions already been solved in the software, and you can go through that by your own time also. Okay, so let's not talk more. We'll start with the solvation. Okay, so let's start with the first question for tonight. A previously fit 55-year-old man has undergone an emergency right hemicolectomy for perforated cecal carcinoma. 2 days after the operation, you note the following on the fluid balance sheet. Intravenous input is 2 liter. Okay, now looking at the question, you should already understand what this is all about. So this is about fluid balance after surgery, right? Then you find out that when did the operation happen? 2 days ago. This is a 55-year-old man. Okay, now look at the fluid balance sheet. You got input and you need output. So this is the input, which is 2 liter. And you can see the output, nasogastric aspiration is 2 liter, drain losses 700 ml, urine output 500 ml. Okay, so now you need to calculate the input and output. And based on that, you need to manage the fluid this patient is deficient of. And they have also given you the biochemistry, which is pretty normal. Which of the but the potassium is little low, as you can see. Normally it should be 3.5 to 4.5. Others are all good. Which of the fluid balance regimens below would you order for the next 24-hour period? So that's your question. Now you know that they're asking you to do the fluid balance for this particular patient after the post-operative period. To understand this sort of question, you need to know the basic formula of this sort of questions. So first thing that you find out that how much is the input in here. So you have given 2 liters of fluid and how much output has happened. So 2 liters in the nasogastric aspiration. Then we have 700 ml drain loss. Then we have urine output 500 ml. And there are always, sometimes there will be some insensible loss of fluid, sometimes from sweating even. So that we usually count as 500 ml. So always add this 500 ml, which we can't see in a patient from where they are losing. Okay. So if we add this up, how much it becomes? So 2 liter plus 700 ml, 500 plus 500. If you do it, it becomes roughly 4 liter. Always make it a round. It becomes easier to calculate. Okay. So you know the input is 2 liter, output is 4 liter. So how much deficit this patient is having, guys? Two liter, very easy, right? So this patient need extra 2 liter. Now the problem happens, it's not only 2 liter, there is always a maintenance fluid a patient needs after post-operation or post-operative period. Now there comes the formula. Any patient after the post-operative, that means after the surgery, their maintenance fluid is 1 liter normal saline plus 2 liter dextrose, okay, plus 20 into, or you can say 20 potassium per liter of fluid you are giving. Okay, so that's the criteria. Now, this will go in each and every patient after the operation. On the top of that, this patient is deficient of extra 2 liter. So you need to add those 2 liter in this ongoing 3 liter. And where we add it, we always add it with the normal saline. So now with 1 liter normal saline, you will add 2 liter, which is deficient of. So how much it becomes? 3 liter normal saline plus the same thing, so 2 liter dextrose. Now come to the potassium amount, 20 per liter of fluid. So how much fluid you are giving to this patient in total? 3 plus 2, 5 liter. So 20 into 5 equal to 100 milliequivalent of potassium chloride. Okay, so now your answer becomes 3 liter normal saline, 2 liter dextrose plus 100 milliequivalent of potassium chloride. This is how you're going to measure it in exam also. Okay, clear guys, any question? Did you guys understand the math? It's very easy if you know it, that's the thing. So always remember 1 liter normal saline plus 2 liter dextrose plus 20 into 20 potassium chloride per liter of fluid. If you remember that, you just need to find out how much deficient this patient is. And the deficient amount, you just need to add it with the normal saline. Clear? Any questions with anyone? Do I need to repeat anything? Good. From where the 100 came. 100 came, this 100 is the potassium chloride. So remember the formula, 20 potassium chloride per liter of fluid. How much fluid you are giving? 3 plus 2, right? So 5. So 20 into 5. 5 into 20 equal to 100. Okay? That means every liter of fluid you are giving, you give 20 potassium chloride. So you are giving 5 liter of fluid. So 5 into 20 equals 100. Children's formula is different. Okay, let's just keep it in the adult at the moment, not the children today. Okay, when we will be doing the pediatric sessions, then we will do that. Next, patient comes back from Thailand with history of having sex with multiple prostitutes. So what we have found out, so it's a recent travel history with a history of unsafe sexual practice. After 1 week, patient presents with lymphadenopathy, mild pharyngeal erythema, splenomegaly, and sore throat. Atypical lymphocytes are present. Monospot test is negative. What is the diagnosis? Do you know when we do monospot test? We do the monospot test to rule out infectious mononucleosis or Epstein-Barr virus infection. But the thing is that you need to first understand that monospot test is not specific. That means sometimes it can be negative, but still patient can have infectious mononucleosis. So it's not highly specific test. And that's in here is your trap. Always in exam, you need to find out where is the trap. This is the trap. Because most of the candidate who has just a shallow knowledge, or they don't know how not to fall into these traps, they will think that, well, this is monospot test negative. And I have read in the JM that monospot test usually positive in the infectious mononucleosis. So as it's negative, let's just cross the idea of infectious mononucleosis from the mind. So what they have done, they have fallen under their own trap. Okay, so that's important to find out that what is the trap in here. Now come to the other things. So this is a Thailand traveling history. That's important. And most importantly, there is unsafe sexual practice. Now, unsafe sexual practice means that it has to be always HIV. It's not something like that. Okay, so next look at that patient presenting with lymphadenopathy, mild pharyngeal erythema, splenomegaly, sore throat. Okay, so their option is HIV, Epstein-Barr virus, cytomegalovirus, hepatitis, and Ross River fever. Now let's have a look to your JM table 28.1. This is the difference between Epstein-Barr virus infection and HIV. So both of them, the onset Epstein-Barr virus usually comes insidious, HIV acute. Fever can be there in both. Fatigue, malaise can be there in both. Now, tonsillar hypertrophy or involvement of pharynx, especially having a sore throat, then pharyngeal erythema, tonsillar hypertrophy, these are mainly common in Epstein-Barr virus infection, not in HIV. Okay, so HIV having sore throat or pharyngeal erythema or even exudates, it's very, very rare. It's not like that it can't happen. It can happen, but not very common like Epstein-Barr virus infection. Whereas mucocutaneous ulcer, like let's say oral ulcer, is very common in HIV. Skin rash is common in HIV. Jaundice is not very common in any of these two. Lymphadenopathy, common in both. Splenomegaly, very common in Epstein-Barr virus and rarely in HIV. Atypical lymphocyte, 80 to 90% cases Epstein-Barr virus positive, less than 50% cases HIV infection. you can also get atypical lymphocyte. Now, what you have found out from this difference, most of the features goes with Epstein-Barr virus infection. If we look at the question again, see this patient having lymphadenopathy, pharyngeal erythema, splenomegaly, that's the most important clue, and sore throat. These two usually is not a feature of HIV. In this case, if I say that, let's say I just cut off splenomegaly and I put oral ulcer, okay, and also I cross the sore throat, then the case becomes HIV. And this is how exactly exam question also comes. Sometimes you will get oral ulcer and then you think about HIV. Sometimes you get splenomegaly, sore throat, lymphadenopathy, you think about Epstein-Barr virus infection. So it's very important to know which is common. All right, so common things always comes first in exam also. HIV can have atypical lymphocyte. Okay, it's not very uncommon, I would say. But again, it's not like atypical lymphocyte can be there in Epstein-Barr virus also. Okay, so that's why in this case, as splenomegaly is there, sore throat is there, we would keep answer as Epstein-Barr virus or infectious mononucleosis. Okay. And Dr. Tithi, yes, the potassium correction is constant. Now look at this question and tell me what you were thinking about the diagnosis. Well, a very good question. I can see someone asks, what is atypical lymphocyte? Okay, it's a kind of like, it's a lymphocyte. Obviously, it's a white blood cell, and that usually you will get it in the process of immune response. Like if you have a bacterial infection, viral infection, your body start producing some specific form of lymphocyte that is called atypical lymphocyte. Okay, let me read this question. A man coming back after short trip from endemic area for only 5 days with severe jaundice. So this is also a travel history positive with severe jaundice is the main feature with fever. On exam, you find out there is tender liver and that's enlarged. So enlarged tender liver, fever, jaundice. You do investigations and found very high ALT, AST, GGT, ALP. What is your diagnosis in this patient? Any patient who is a traveler, okay, so recent travel history coming to you with fever and jaundice. The most important two differential diagnoses should come into your mind is that, is it a malaria? Is it hepatitis? Okay, if only fever, high fever in 5 days time, we also keep dengue in our differential diagnosis. Now the question is it always malaria? If someone coming from an endemic area and like they haven't told what type of endemic it is, right? Is it a malaria endemic area or hepatitis endemic area? We don't know. Okay, so we just know that it's a short trip from somewhere for 5 days, patient coming to us with fever, jaundice, tender hepatomegaly with the raised ALT, AST, GGT. That's the only thing that we know. From that part, are we going for malaria or we are going for hepatitis? There is no option of dengue in here. So we don't need to think about dengue at the moment. And think about dengue if you get fever with rash, because that's common presentation. Jaundice is not very common in a patient with dengue, Rather, fever jaundice in a patient with traveling history can have malaria, but not dengue. But in here, the most important clue is this one, the tender hepatomegaly. You don't get tender hepatomegaly in malaria. Very unlikely. Well, you can get jaundice, you can get high AST, ALT, but tender hepatomegaly, usually we should look for it. If you look here, tender hepatomegaly usually positive in viral hepatitis, CCF, liver abscess, or sometimes enteric fever. So these are the usual causes or common causes of having a tender hepatomegaly. With tender hepatomegaly, if you get raised AST, ALT, okay, so these are the liver enzymes, then you should always think about viral hepatitis. Now, someone coming from endemic area, are we thinking about hepatitis A or B? Usually we should think about hepatitis A at the time because hepatitis B doesn't occur only in travelers, but travelers more common to get hepatitis A than a hepatitis B because hepatitis A mode of transmission is fecal-oral transmission and Hep B usually transmits through sexual transmission. So in here, if there is a sexual history, which was unprotected sexual history, then we could think about hepatitis B. Okay, cool. So if there is tender hepatomegaly, we should think about hepatitis. It's not only children, Dr. Addy. Adult can get tender hepatomegaly also. I have seen a couple of patients having tender hepatomegaly and they were adult. There is nothing like it can't happen in adults. But yes, it's common in children. But yes, there is a lot of adults who get hepatitis A with tender hepatomegaly. Okay. Also, one of the important thing, can anyone tell me that how we should not think about malaria for this patient? Look at the duration. It's just a 5 days. Within 5 days, malaria doesn't present. There is an incubation period of at least, if it's a falciparum malaria, at least it should be 7 days. Within 5 days, it's very unlikely any malaria will present to you with symptoms. Okay, that's one of the very important clue in here. So we have to be very vigilant during our reading the questions. Reading questions give you a lot of things. Okay, so think about everything when you are answering something because most of the questions answer will be very similar and you just need to rule that out based on what you see in a question. And yes, hepatitis B is gradual also, but hepatitis B also has a long incubation period, not 5 days. Now, the basic thing that you should remember is that if you get a patient with a fever jaundice, okay, there is raised AST, ALT, and you found that patient having tender hepatomegaly, we should consider hepatitis first rather than malaria only. And that doesn't mean that we will not check malaria in this patient. We will check for malaria in here also, but the common thing, what is the most common likely cause in this patient? Viral hepatitis A. And in case of hepatocellular jaundice, which occurs in viral hepatitis, what you will get positive? Usually AST, ALT will be very high. You can get high, and as ALP is high in this patient, will you consider it as choledocholithiasis, like bile duct stone, just because ALP is high and jaundice? No. Because if it's a stone in the common bile duct, it's not related with the traveling history he is having. And also, only if there is a bile duct stone, okay, it's very unlikely that it will be a case of like coming with a fever, unless this patient develops septic or toxic shock from an obstructive jaundice. All right. And again, in choledocholithiasis, usually you don't get tender hepatomegaly. That's the thing. So tender hepatomegaly is important. And that's very important, Dr. Nisha. Yes, for malaria, splenomegaly is more common than hepatomegaly. Next, let's move on to the next topic. So you have got a patient who came to you after falling from a bicycle about a week ago. So duration is very important, and associated helmet fracture was there. No confusion, no amnesia. But patient has headache which increase with coughing. If a headache gets increased with coughing, you should think about raised intracranial pressure. What is the most likely diagnosis? So you think about intracranial hemorrhage or intracerebral hemorrhage, subarachnoid hemorrhage, extradural hemorrhage, subdural hemorrhage, or concussion. The very important clue in here is that, like, it's very hard, I would say, just to say what is the diagnosis based on what they have given, but they ask you what is the most likely diagnosis. If you look at here, patient had a bicycle fall about a week ago and helmet fracture happened. So that means if helmet get fractured, that was a hard blow. Okay. And very unlikely to be extradural hemorrhage. In extradural hematoma or extradural hemorrhage or epidural hemorrhage, okay, in epidural hematoma, you get a classic presentation in which patient get a fall, injured the head, and they lose consciousness. And then just maybe hours later, the patient becomes completely normal. So regain consciousness and as if he's totally fine. And that is the lucid interval they usually show. And once the lucid interval is over, then they fall into prolonged unconsciousness. So this period happens more commonly in epidural hematoma rather than subdural hematoma. But in here, you don't see any confusion, nothing like lucid interval or anything. But most importantly, he had a fall which resulted in helmet fracture. That means most likely it's involving deeper area, which is most likely to happen is subdural hematoma. Okay, and also the onset of symptoms is important. Epidural hematoma presents very acutely. Okay, and subdural sometimes it comes as a subacute presentation many times, like this case. Okay, so that's why we will choose it as a subdural hematoma as our diagnosis. There is a lot of things to discuss about it. So epidural hematoma usually occurs from a blunt trauma causing laceration of the arterial vessels, usually middle meningeal artery laceration. The fracture usually occurs around the region of temporal bone. In contrast to subdural hematoma, tremendous force is usually required. Triphasic presentation is very important. This presentation commonly comes with epidural hematomas, which means you will get the phase of brief loss of consciousness, followed by a lucid interval, and then followed by a prolonged unconsciousness. If you do a CT scan of epidural hematoma, you will get a biconvex shape. See the biconvex shape here? So that's your epidural hematoma. In case of subdural hematoma, usually if the head trauma causes rupture of the breathing veins, subdural hematoma usually occurs. Sometimes in contrast to the epidural hematoma, the symptoms are very subacute or even chronic. Okay, but you can get headache, you can get altered mental status, Okay, and sometimes in elderly, patient can present with chronic subdural hematoma causing dementia. And that is what we call vascular dementia in elderly. And that's the reason if any elderly patient present to you with dementia-like feature, and that's very acute presentation, and there was a history of head injury or just a small minor fall, you should always do a CT or MRI of the head to rule out this subdural hematoma. Maybe patient having a vascular dementia and we don't know that. And if we don't do the CT scan, we just miss it. Okay, so that's why any patient, elderly patient coming to you with an acute onset of dementia, let's say even subacute, 3 months, 4 months, and had a history of fall, or maybe just a small knocked into the door, you should always rule out this chronic subdural hematoma in this patient. If we do a CT scan of the head, what we will find out, we will get this semi-lunar finding. See the semi-lunar area? Okay, that's what you get in case of subdural hematoma. Okay, so that's very important to remember. All right, come to the next question, genetics. Very commonly asked in the exam, and you should have at least some basic idea about genetics in the exam. Parents come to you telling that their son has hereditary spherocytosis, and they want to know that what is the chances that his siblings will get the same disease. That means what son's siblings. That means they are asking that what is the chance of their next child to have the same disease. Hereditary spherocytosis, it's a autosomal dominant, recessive, or X-linked recessive disease. What do you think? That means in here you should know the common example of this hereditary pattern also, like some of the common diseases which causes autosomal dominant features, some of the example of autosomal recessive diseases and X-linked diseases. So you should know common examples for that, at least to answer these questions. So yes, it's an autosomal dominant pattern of inheritance in case of hereditary spherocytosis. So what is the chance of having the next pregnancy to get the same disease? 25% of his brothers, 50% of his sister, 50% of his brothers, 0% of his brother and sister, and 50% of brother and sister. What do you think? Always remember, if it's a autosomal dominant pattern in each pregnancy, there is a 50% chance of having diseased child and 50% chance of having a normal child. And you can't say that if the daughter or the son will get it, because any of them can get it in here. Autosomal dominant, both daughter and son can be equally affected. Okay, so your answer should be 50% of his brothers and sisters. So in each pregnancy, there is a risk of 50% child being affected and 50% is normal. Now, how can we know that, right? Obviously, we should not memorize this sort of things. We should know what we are learning. So let's just discuss about it. Now, for the purpose of easy understanding, we will keep the male as XY and female as XX. But don't think that always will be XY, The autosomal dominant and recessive, they don't involve your X or Y chromosome. Okay, so it's not like we are talking about X-linked disorder. We're talking about autosomal dominant and autosomal recessive, and it doesn't involve your X chromosome. It's just a pattern to show you that this is a male patient and this is a female patient. Okay, don't get confused with the XY and XX. Now let's say this gene is abnormal in this male patient. Okay, let's say this male patient having hereditary spherocytosis. So he's a diseased person, and this Y gene is defective in his case. And he married to a normal female, and she doesn't have any disease. Okay, and now when they have kids, there are 4 patterns that can happen. So this one, XX, can be happening. So we are discussing the genetic pattern that can happen, right? Then this X. Now these 2, so Y prime and X, and now this one, so same Y prime and X, right? Now if we look at here, this kid has got this defective gene, okay? And for being autosomal dominant, you need only one gene to be affected. So for dominant, if your dominant gene is affected, you get the disease. Whereas in case of recessive pattern, you need at least 2 genes to get mutated to get the full-blown disease. We'll just come to it later on, don't worry. So for dominant, if you get 1 defective gene and that was dominant gene, you get the disease. So this kid is getting the disease. Same with this kid also getting the disease. So how much is diseased? 50% is diseased. And this one is healthy, this one is healthy, so 50% is healthy. All right, so this is how we find out. Again, remember, it doesn't mean that only sons will be affected and daughters will be normal. It's not something like that. We don't determine it by XY in dominant or recessive pattern. Okay, so any of the brothers and sisters can get the disease equally. And the term that you need to remember, 50% of daughters and son will get the disease and 50% will be healthy in each pregnancy. It doesn't mean that one son has got the disease. That means all from 50%, 25% is gone. Now only 25% will get the disease. It's not like that. A lot of candidates make it wrong in that way. Okay, it's in each pregnancy, 50% will be either diseased or 50% will be healthy. That's the term you need to remember. Cool. Now come to another pattern, autosomal recessive. In case of autosomal recessive, let's say we again use the same pattern. Okay. Now in here, in autosomal recessive, let's say both of them are carrier, like thalassemia minor. So father is thalassemia minor, mother is also thalassemia minor. Both of them are carrier of the disease, but they are not affected. Okay, that means they are not having a full-blown disease. They are just carrying one defective gene. And now they have married. What will happen to the kids? So use this one. So X prime and X prime. And this one will go with this one, X prime X. Now this one with this one. So X prime and Y. And this X with this Y. So these are the 4 possibilities. What we have found out in here. X prime, X prime. Both of the gene is defected, right? And this is the 25% who will be diseased. So 25% chance of having a diseased kid, full-blown diseased, thalassemia major. This one is a carrier because only one gene is affected. This one is a carrier because only one gene is affected. Okay, so 50% is carrier and 25% is healthy. Okay, so this is how you find it out. It's very commonly asked in the exam that if there was a carrier father and carrier mother, what is the possibility of having a diseased child, or what is the possibility of having a carrier child in the next pregnancy. So if both carrier father and mother usually give birth, so then we need to think about 25% will get the full-blown disease, 50% will be carrier, and 25% will be healthy. Is this clear, guys? Do you understand what I'm talking about? Good, very good. You guys are doing really great. Lots of people usually have difficulty with these sort of things, but you guys are getting it very good. All right. Now, let's just discuss X-linked recessive. When I say X-linked recessive, it means that the defect should be in the X chromosome only. Okay, let's say XY have one in here. Okay, this one. Look at this one. In case of X-linked recessive inheritance, let's say father has the condition. Okay, so let's say father in here, this is XY, you can see, and this is the mother XX, and father is having the condition. That means father is diseased in here. And why X-linked recessive pattern is usually, you will always, like most of the time, you will get it, diseased population will be the male population. Okay, most of the time. You will see why. Now, if they marry, what will happen? So we have got XY, this is normal. XY, this is normal. Okay. In here, one X which got the diseased gene from father and another is normal. Same with here. Both of the daughter in here are carrier because they have one defected gene. In here also one defected genes, but this one defected genes get counteracted by the normal X chromosome they are having. So that's why female usually become carrier most of the time. Okay, because they have two X. But let's say just opposite thing if we do. Let's say mother is having the condition. To have the condition, mother has to have two defective genes. Okay, or we can try with this one. Let's say XY, XX. Mother is carrier and father having the condition. All right, so what happens at that time? So this one will go to this one, X prime, X prime. Then this, X and X prime, X prime Y, and XY. Now in here, two things is the possibility. One possibility, as you can see here, is that this female child can be diseased because her both X is defected. This one will be carrier because her only one X chromosome is defected. This one will be healthy. This one, what do you think this one will be? Diseased or carrier? This son. Diseased because he has only one X chromosome and that is diseased. So he will be also diseased. So this is one possibility. Another possibility could be father is all right. Let's say mother is the carrier. Okay, and they are married. What will happen? x prime, this x goes with this x, y and x prime, and this y comes with this x. This is more common, okay? Now, look at this one. This one is diseased or carrier. Carrier, right? Because only one X is diseased. So she is carrier, she is healthy, he is healthy, and this son will be diseased. Okay? So this pattern is more common in X-linked recessive pattern. And that's why I said mother gives to the son. Okay, so in case of X-linked recessive inheritance, mother gives the disease to the son most of the time. Okay. Can you tell me one of the common X-linked recessive disease? Hemophilia, right? So that's why we always ask that maternal familial history of having a bleeding disorder. In hemophilia, that is common. Usually in the maternal side, someone will have bleeding disorders. Okay, very good. So that was all about these genetics that you guys need to remember. All right. Any questions so far? So now any questions come from genetics, at least this, like how much percentage will be affected, you guys will be able to find it out. Okay, the next question. You have got a lady coming to you with weakness of lower limbs. Let's say it's a 50-year-old lady. She drags her foot while walking. Dorsiflexion, plantar flexion is weak. Reflex exaggerated, but absence of plantar response. What is the diagnosis? Now, these sort of questions are very confusing in the exam actually, because if you look at here, it's hard to say which is the exact diagnosis in this case. But look at the pattern of the question first, and also the options, because option will give you some idea that what could be the reason. They're asking the diagnosis, so you need to answer something which is going with the diagnosis. All right. Look at the options: cervical spine MS, motor neuron disease, spinal canal stenosis, and lesion in the cerebral cortex. Now look at the question. So it's a weakness of lower limbs, right? So both limbs is having weakness. Dragging while walking, so that's also related with the weakness. Dorsiflexion, plantar flexion is weak. Reflex exaggerated. And absence of plantar response. The term that we use in here is that if someone has both upper motor neuron and lower motor neuron type of feature in the same limb, like this patient having weakness, having reflex exaggerated, but absence of plantar response. So what she's having a mixture of upper motor neuron and lower motor neuron type of palsy. When we get something like that, we immediately think about motor neuron disease. Okay? Look at the spinal canal stenosis. It doesn't give you lower motor neuron type of feature. It's most of the time will give you an upper motor neuron type of feature. Same with the cervical spine MS. Usually it should not be cervical spine MS, it should be cervical spine myelopathy. Okay? Even if it's a myelopathy, it's should be given to you a upper motor neuron type of feature, and feature should be more common in the upper limb, not the lower limb. Okay, so this is unlikely to be here. This is unlikely to be here. Now, lesion in the cerebral cortex, is it a diagnosis? No. If they would ask you that where is the lesion, then you would think about lesion in the cerebral cortex. Is motor neuron disease is a lesion in the cerebral cortex? Yes. Because motor neuron disease, cerebral cortex, motor neurons, right? So this is a way of making people confused in the exam. If in the exam they ask you that what is the diagnosis, you don't say that it's a lesion in the cerebral cortex. Is it an appropriate diagnosis? No. What is the more appropriate diagnosis in here? Motor neuron disease, right? Because this patient has both upper motor neuron and lower motor neuron type of palsy in the same limb. Okay. Now look at the next question. We'll discuss the upper motor feature and lower motor feature, but look at this one. The same question, it's a 58-year-old man, dragging left foot, reflex are increased, plantar flexion, dorsiflexion weak, weak ankle movement, absence of plantar reflex, upper limb and face normal. What is the lesion site? Now, what is the lesion site in here? Diagnosis, again, it's a motor neuron disease. Now you look, is it a common peroneal nerve involvement, cervical spinal cord? If it's a cervical spinal cord, upper limb should be affected. So rule that out immediately. Common peroneal nerve, it's a peripheral nerve. It doesn't give you upper motor neuron type of palsy. Cross that out. Same with the L5S1 nerve root. L5S1 nerve root doesn't say that why there is absent of plantar reflex, doesn't say that why she is having both lower limbs is weak. Okay, so unlikely. And most importantly, L5S1 should not give you a increased reflex. Brainstem, if it was brainstem, you should get brainstem features like diplopia, nystagmus, trouble swallowing, some changes in the voice. So no brainstem features are there. So rule that out. So only thing remaining is cerebral cortex. And you already know that motor neuron disease affects all the motor neuron in your body. It doesn't affect your sensory nerve, just the motor neurons. So motor neuron can be in your cerebral cortex, can be anywhere, right? So any motor neuron can be affected. And this is the homunculus that you can see. Homunculus, it's not important for you. So just if you look at here that all the movement and everything is controlled by your hemisphere. So you can see your leg is controlled by this area. You can think that why, if the cerebral cortex is involved, why the face is not affected? Because maybe only thing affected is this area and the face is spared. Okay, so that's why. And this is your upper motor neuron and lower motor neuron type of palsy. The difference between these two is quite easier, and I guess all of you know it. And we'll discuss it in detail in our neurology class. But just to remember that patient with upper motor neuron type of palsy, they give you a paraplegia or most commonly hemiplegia, like in a stroke patient or MS patient. In lower motor neuron type of palsy, you get flaccid paralysis. Okay, in upper motor neuron, you get spastic paralysis, paraplegia or hemiplegia. Muscle tone will be increased in upper motor, decreased in lower motor. Fasciculation, muscle wasting is common in lower motor, absent in upper motor. Reflex gets increased in upper motor neuron, absent or decreased in lower motor. Okay, so that's pretty much everything. And in case of plantar response will become extensor in case of upper motor. In lower motor, it's absent or reduced. Okay, cool so far. Now guys, we'll take a 10-minute break. And we will start discussing the other important questions after this break. Okay, so let's take a 10-minute break first. Are you guys getting me so far? Any questions? I'm going very slow because this is the first time we are discussing questions with you. So I just need you to get adapted with my approach. But normally we go very fast, I would say. All right, so let's take a 10-minute break and then we will start again. Thank you all. All right, guys, let's start again. Yes, Dr. Monira, it will be recorded, the class. Now, next come to one of the very commonly asked question in exam, which is the cardiovascular chart and cardiovascular risk assessment. We use a chart, which is the 5-yearly CVD risk factor chart. And to use that chart, you need to have a little idea about how this charting works actually, okay? There is a very good guideline on Australia about it, but still a lot of candidate has some difficulty understanding it. So we'll discuss about it very quickly. Have a look to the question first. 64-year-old smoker, women coming to you with a blood pressure like this, with a cholesterol HDL ratio of 6.6:1. The CVD chart is given, and they are asking what is her, not his, what is her 5-yearly CVD risk. Okay. Now, to find out this CVD risk for these women, we need to use all the information that we need. So first of all, this is a women, and you can see it's a people without diabetes chart. Okay. And is it a smoker or non-smoker? So look at here. So we can see it's a smoker and 64-year-old. So we have got women, smoker, and 64-year-old. So 64-year-old will go in this age group. That means we are looking into this area only. See that we don't need to even look into any other part, just this part. Okay. Now you need systolic blood pressure, as you can see in the y-axis. And in the x-axis, you have total cholesterol and HDL ratio. So you need these two information. First of all, let's look in the systolic blood pressure. What is the systolic blood pressure in these women? 135, right? So where 135 will fall? Now look at this one. This is 120, 140, 160, 179. Always remember the maximum number of systolic blood pressure which will fall in this lowest area. So in here up to this, it will be 130, not 120. Okay, so what will be the maximum of this one? 150, 170, and so on. Now, if it is 135 we are looking for, where it will be? In the first box or second box? Obviously second box, because up to 130 is the first box, and in the second box we have 135. So it will be somewhere in this second row or column, as you can see. Okay. Now you look for cholesterol and HDL ratio. 6.6:1. Now have a look in this one. This is 4, 5, 6, 7, 8. But what is the maximum of this box? 4.5. Okay. This is maximum 5.5, 6.6, 6.5, 7.5, 8.5. That means 6.5, where it will fall? First, second, third, fourth, fifth. Which box 6.6 will fall? Guys? (6.6), remember it. Very important to understand that maximum of first box is 4.5. Second box 5.5. Third box 6.5. That means in the third box 6.5 will not be there. In the fourth box maximum is 7.5. So 6.6 will fall under your fourth box. Okay? Is this clear? Very important. Very, very important, because this is how candidate get it wrong. Okay, now you go up. So in this age group, if you go up, 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 so where is your point? in this yellow, right? So now you need to just compare this yellow color, and in the exam, you will be given that yellow color, how much risk it is, red color, how much risk it is. For each of the color, there is a percentage of risk that will be given in the exam also. Now let's say, what if it's marginal? Let's say someone's blood pressure, systolic blood pressure is 130, where it will fall. We know the maximum for first box is 130, right? The thing is, if you get something marginal, you should pick the next box. That means if it is 130, you will pick this box. If it is 150, you will pick the next box. Same with the cholesterol HDL ratio. If someone's cholesterol ratio is 4.5, you will pick the next box. Is this understandable, guys? Now let's look at coloring. This is given in your Australian guideline. So let's have a look. So this is the cardiovascular risk chart, and see that this is the coloring that I was talking about. Our patient got this yellow marking, right? So let's see what our patient got. And the yellow has also lots of other things. So she got the like this yellow, right? So if we compare that yellow, so that yellow is 16 to 19%. So this is our patient risk factor of having a CVD risk, or you can say 5-yearly CVD risk for her is 16 to 19%. And she is high risk. Okay, so this is how we will find it out in the exam. Just give it a read from this one. You will get an idea as well. And the thing that I talked about is here. It's written in here. As you can see, within the chart, the left lower cell contains all non-smoker without diabetes who are 35 to 44 years and a total cholesterol HDL ratio of less than 4.5. So they're talking about this one. Let's say this one. So first box, the total cholesterol ratio is less than 4.5. So if it is 4.5 in marginal, then it will come in this next box. And the systolic blood pressure is less than 130. So systolic blood pressure in here will be less than 130 in the first box. Okay, so this was what I was talking about, and this is from guideline. Lots of people will show you a lot of other things. Do not even hear those things, because if this sort of question comes in your exam and if you get it right, there is an increased chance of getting a high mark in the exam. Okay, because these are hard things and time consuming, and usually it carries more mark. Okay, let's move on to the next. The patient that has been shown in this figure, he got a stabbing wound to the back of the left forearm. So this is the left forearm. In here, she got a stabbing wound, and she's trying to straighten his finger. So he's trying to straighten his fingers on command. You can see this hand, he is able to straighten it or do the extension of the wrist and fingers. In this hand, he is able to do the extension of the wrist, but not the fingers. And the question is, which one of the following nerve is most likely been injured? To understand these sort of questions, you need to have a basic idea about the hand nervous system, which usually comprises of median nerve, ulnar nerve, and radial nerve. We'll discuss the radial nerve today. These are your options. Let's discuss it and then we'll come back here again. Radial nerve, if you look at this picture, it starts from your just brachial plexus, and then you have, this is the axillary area, and it usually gets rounded in the spiral groove of the humerus, and then it comes forward, and then it At the elbow, it gives you two branches, which is one is posterior interosseous nerve and another is superficial radial nerve. Okay, so this is your radial nerve branching. So it can get injured anywhere in the hand and arm. So it can get injured in the axilla. It can get injured in here in the mid shaft of the humerus, can get injured at the elbow, and can get injured in the forearm or in the wrist. So how we know which part is injured and where the injury has occurred? And if injury occurred, then which part of the nerve has got injured? So lots of things, right? It's a complicated thing. Try to understand it. I hope that you will get it. Now, radial nerve injury. First of all, let's discuss about injury at the axilla. First, we need to know what is the motor function of radial nerve and what is the sensory function of radial nerve in the hand. The motor function of radial nerve is it helps with the extension of the forearm. Okay. With that, it also helps with supination and it helps with extension of hand and fingers. That means radial nerve mainly helps with extension. So your extension of the elbow, extension of the wrist, extension of the fingers, every extension usually will be done by the radial nerve. Okay. The sensation, if we look at here, this is the dorsal aspect of your hand and this is the palmar aspect of your hand. Palmar aspect is supplied by median nerve and ulnar nerve. Median nerve gives this thumb, index finger, middle finger, and half of the ring finger. And this is the median nerve. Ulnar nerve gives half of the ring finger and the little finger. Whereas the radial nerve mainly gives supply to your dorsal aspect of the thumb, index, and middle finger, you can say. And ulnar nerve usually gives the other part. Okay, so this is the sensory area of radial nerve. Now come to injury at the axilla. If there is injury to the axilla, everything will be damaged because that's the origin of radial nerve. So if the origin is affected, that means you will have loss of extension of forearm. Okay, you will have loss of extension of wrist, as well as you will have loss of extension of finger. So every extension will be weak. So that's the motor deficit you will get here. Sensory deficit, so you will get loss of sensation on the lateral arm, posterior forearm. With that, the dorsal aspect of the radial 3.5 fingers that we said. So this part. So dorsum of the hand with that lateral 3.5 fingers will have loss of sensation. Okay. That's your injury at the axilla. Everything is lost. What if there is a fracture of mid shaft of the humerus? Remember the area? Let's say there is a fracture in the mid shaft of the humerus. Then what is the presentation? Everything will be same like axillary injury. Only difference is in the sensory loss. In here, there will be no loss of sensation in the posterior forearm or arm like axilla, but there will be loss of sensation only in the radial 3.5 fingers. That means only the finger loss of sensation will be there. No loss of sensation in the arm or forearm. Okay, this is how you differentiate. Come to below or at the elbow. So around the elbow joint, if the radial nerve get injured, what you will find out? Around the elbow, the most likely nerve which will get injured is the branch of radial nerve, which we call posterior interosseous nerve. Remember, posterior interosseous nerve, this is the posterior interosseous nerve. Okay, it's only motor, it doesn't give any sensory branch. That means you will not have any sensory loss in here. Very important. Only positive finding you will get is the motor deficit which will be loss of extension of finger only. So it only helps with finger extension. Your wrist extension will be fine in here. Everything will be fine. Only problem will be finger extension. So only thing you will get is a finger drop. If you ask the patient to straight finger, they will not be able to do that. So that's your elbow. If it occurs at distal forearm, okay, or around the wrist joint, which usually can occur like if someone get a stab wound or laceration of forearm, then they can injure the superficial branch of the radial nerve, which is entirely sensory. Okay. If it is injury at the distal forearm and it injures the superficial branch of radial nerve, only finding you will get is loss of sensation in the radial 3.5 finger. Okay, so no motor loss. So now you understand. So if it is axillar, then there will be loss of extension of forearm, wrist, and finger. Sensory loss will be on the arm, forearm, and also radial 3.5 digit. If it is at the midshaft, everything is same like axilla, only there will be no loss of sensation in the arm and forearm, only there will be loss of sensation in the radial 3.5 digit. If it is occur around or below the elbow, no sensory loss, only finding you will get is finger drop. That means loss of extension of finger extension. If it is the superficial branch of radial nerve is injured, which is more commonly occurred if someone get injury at the distal forearm or at the wrist, you will get only sensory function loss in the radial 3.5 finger. Very easy now. Now you tell me what's your answer. You've got a patient like this. Okay. Looking at the features, what do you think this patient has got? So you ask the patient to straighten the hand, and you can see the wrist extension is fine, but there is finger drop in here. That means finger extension is lost. Nothing has been told about loss of sensation anywhere. So which nerve is injured? Yes, posterior interosseous nerve, most likely. Okay, now if you choose radial nerve, will it be wrong? It's not wrong, but if you have a better option, why you will choose radial nerve? That's the thing. They want you to choose the most likely nerve which is injured. When you know that this is most likely posterior interosseous nerve, why you will choose radial nerve? That's the thing. It's not anterior interosseous nerve because anterior interosseous is a branch of median nerve. Okay, we'll discuss about those in our courses, the other two nerve, radial nerve and ulnar nerve loss, not today. Okay. Now come to another nervous system related issue, which also comes frequently in exam. You've got a 64-year-old woman complains of dragging her right foot and numbness and paresthesia in that leg. On examination, there is foot drop with weakness of dorsiflexion, inversion and eversion of the ankle. The reflexes are normal. There is loss of appreciation of pinprick on the outer side of the lower leg. Which nerve root or nerve is most likely injured in her? So very important to understand the question first. What is the presentation? Dragging her right foot. This is most likely it's a foot drop. Okay, and on examination, you can find out there is foot drop. So you need to find out what causes foot drop in a patient. Now you look at motor loss and sensory loss. you can see motor loss is dorsiflexion, inversion, eversion. Reflex are normal, which is very important finding in here, you will see. And there is loss of appreciation of pinprick, that means loss of sensation on the outer side of the lower leg. So if this is the lower leg, this looks like a leg of a cow, but just let's assume this is a human leg. Okay, so this is the outer side. So they're asking outer side of the lower leg sensory loss. Outer side is given by number 5 normally, right? So we'll look into that. So you can see L4 nerve root is one option, L5 nerve root, superficial peroneal nerve, tibial nerve, and sciatic nerve. To understand which nerve has been damaged, you need to know the function of each and every nerve which is in the option. Otherwise, how you will come to your conclusion. So let's just discuss about the lower limb neurology, what usually is important and how you can find out your answer. The very important is foot drop can be due to L5S1 nerve root problem, especially L5 nerve root problem. It can be due to similarly common peroneal nerve problem also. First of all, let's have a look. Your common peroneal nerve is a branch of sciatic nerve that comes from lumbosacral plexus. Okay, so let's say this is in here, there is hip, and from here there is lumbosacral plexus, and from here you have sciatic nerve coming down to your thigh, and when it comes here, sciatic nerve divides into 2 branches. Okay, one branch is tibial nerve and another branch is common peroneal nerve. So this common peroneal nerve, then around the head of the fibula, this is fibula, around the head of fibula, it rounds and it comes forward and it gives supply to your anterior portion of the leg, this portion of the leg, anterior side. And tibial nerve runs through the posterior surface of your calf. Okay, so in the posterior surface of your lower leg, which is the calf, supplied by tibial nerve, and in the anterior area, supplied by your common peroneal nerve. Common peroneal nerve, when it comes in the front, it divides into 2 branches. One branch is called superficial peroneal nerve, and another is called deep peroneal nerve. Okay, so common peroneal nerve is a branch of sciatic nerve. Sciatic nerve divides into common peroneal, gives you common peroneal and tibial nerve. Common peroneal nerve gives you 2 branches. One is superficial peroneal, another is deep peroneal. So far, all good. Very complicated thing, but if you understand, then you will never ever forget it. Come to the function of this common peroneal nerve. Common peroneal nerve, when it divides into superficial and deep peroneal nerve, it gives you some motor supply and sensory supply. First, discuss the motor function. In an easy way, you can just remember common peroneal nerve gives ED. What is ED? Emergency department? No, it's eversion and dorsiflexion. So common peroneal nerves helps with eversion and dorsiflexion of your ankle. Okay. Now come to the branches. This D, you can see that D is given by deep peroneal nerve. That means dorsiflexion will be given by deep peroneal nerve and eversion will be given by superficial peroneal nerve. Okay, see how easy it is if you know these things, and very interesting also. Now come to the sensory. Superficial peroneal nerve gives supply to the entire anterior side of the leg as well as your dorsum of the foot. That means the whole area, this area, dorsum of the foot, will be supplied by superficial peroneal nerve. Deep peroneal nerve only supplies this part. That means the first wave space between your first and second toe. Okay, so first wave space will be supplied by your deep peroneal nerve. Everything here will be supplied by superficial peroneal nerve. That means common peroneal nerve supplies the whole anterior leg and dorsum of the foot, right? Okay, so now you know the sensory function, you know the motor function of common peroneal nerve. If we go to the tibial nerve, it gives sensory supply to the calf, that means posterior surface of your leg, and it helps with plantar flexion of your foot. Now, just by knowing all this information, you can cross out tibial nerve, because this patient having dorsiflexion, inversion, and eversion is lost here. Okay? Cool. Then come to the sciatic nerve. Remember one thing, sciatic nerve gives a sciatica-like features, which usually patient come to you with back pain, which shooting down through the buttock, posterior aspect of the thigh, and going down up to the foot. So shooting pain coming from the back, that is sciatica, and usually the features will be like that. That's sciatic nerve compression features. Okay. Then come to the L4 nerve root. If you guys know the dermatome, let me show you the dermatomal things first. So if you look at here from the anterior side, you can see the medial side of your leg or inner side of your leg will be supplied by L4 and outer side or lateral side by L5, right? And the outer side or lateral side of your foot will be given by S1. L3 is usually over the knee joint, just this area, and L2 is the thigh. Now come to our question. Loss of sensation on the outer side of the lower leg. So is it L4? No. If it is the L4, at least it has to be inner side. So you can cross that out. You cross these two also. Now you have superficial peroneal nerve. Superficial peroneal nerve gives supply to the entire anterior leg and dorsum of the foot, not just outer side of the lower leg. And on the top of that, superficial peroneum only helps with eversion. But this patient having loss of dorsiflexion, inversion, and eversion. So this is also out. So what else we have? We have L5 nerve root. Remember one thing, L5 nerve root doesn't give any reflex. That means in here you can see reflex is normal. And L5 helps with dorsiflexion, eversion, inversion. Okay, these three things are given by L5 nerve root. And you can see that there is loss of sensation on the outer side of the lower leg. Everything goes with L5 nerve root. Now, if there is an option in here, common peroneal nerve, will you choose that? Sciatica can be unilateral or bilateral. And again, if it is sciatica, what will happen? Sciatic nerve is the mother of everything, right? So common peroneal nerve features will be there, tibial nerve features will be there. So you will also get loss of plantar flexion. If it was a sciatic nerve, everything will be lost at that time. Yes, very good. So you will not choose common peroneal nerve because common peroneal nerve doesn't help with inversion. And the loss of sensation will not be only on the outer side of the lower leg. It will involve the whole anterior side of the lower leg as well as the dorsum of the foot. Right? So this is how you come to your diagnosis. It's very important to understand each and everything that I talked about. Otherwise, in exam, they will change the scenario and you will be confused which one to choose. Also remember, the knee jerk or knee reflex is supplied by L3, L4. So if it is a L4 nerve root problem, you will probably get knee reflex lost. Same with the ankle jerk, supplied by S1, S2. But L5 doesn't give any reflex. Clear, guys? Any question? Good. Next, move on to the next topic, pneumothorax. So you have got a 15% pneumothorax in a young person with asthma. Just uses salbutamol when he has upper respiratory tract infection. Saturation is 95%. What to do? Okay, so this is your question. 15% pneumothorax in a person with asthma. What is the type of pneumothorax this patient is having? Is it primary spontaneous or secondary pneumothorax? That's the question. Secondary, right? Because this patient having asthma. Okay, that's very good. All right, now let's move on. So pneumothorax, you guys, all of you know what is pneumothorax. I don't need to go into the definition of it. So pneumothorax can be primary, can be secondary, which means primary means there is no underlying cause. And secondary means there is some underlying lung cause, and that resulted in pneumothorax. Sometimes patient can get a trauma and can get pneumothorax. That's also secondary pneumothorax. Okay, so we have got primary spontaneous pneumothorax. We have got secondary pneumothorax, two types, and the management is totally different or mostly different, you can say. In case of primary spontaneous pneumothorax, we need to look for how much percentage of lung has been involved and if this patient is symptomatic or not. Which is more important? If the patient is symptomatic or not. Any patient is symptomatic, whatever size of pneumothorax it is, it doesn't matter. You need to go for treatment. You can't just wait and observe. Okay, now let's divide it into three parts. First one, patient having a small pneumothorax, and it's small means less than 15% or less than 2 centimeter rim of air in the lung. It will be given in your exam question. So just remember it, with minimal symptoms. That means this patient is maybe having just a mild shortness of breath, okay, but nothing else. No severe chest pain, no severely short of breath, not hypoxic, nothing like that. So a small pneumothorax, you can just observe the patient in the emergency department. So observation. If it is large, let's say more than 15%, but minimal symptom, In that case, if patient is not having that much symptom, you can just give oxygen. Because oxygen helps with reabsorption of the air that has escaped into the pleural space. So that's why obviously we will observe the patient, but keep some oxygen. But again, it depends on the oxygen saturation. If oxygen saturation is low, then you give it. Otherwise, no need. Look at this one, large or small. Doesn't depend on the percentage or any of it, but patient having significant symptom. That patient should go for immediate catheter aspiration. Or you can say needle thoracocentesis. Okay, previously we would do needle thoracocentesis only in patient with tension pneumothorax, right? But nowadays, any patient before going for intercostal drainage, if you want to go for it, before that you should try this one first, catheter aspiration or needle thoracocentesis. And that's according to your AMC handbook. The guideline has been changed, okay? So you need to first do the catheter aspiration or needle thoracocentesis. That means passing a needle into the second intercostal space. All right, so draw out the air that is accumulating in the pleural space. And then if still patient symptomatic, you can go for intercostal tube drainage or chest drainage. So this is the management that we need to remember. Okay, clear guys? So if it's a small with no or minimal symptom, only observation, large or minimal symptom, oxygen can be given if saturation is low. Large or small but significant symptom, needle thoracocentesis or catheter aspiration. That doesn't help, the last option will be tube drain or chest drainage. Now let's say you did a catheter aspiration. When you should consider inserting a chest drain? These two are very important to remember. If when you inserted the needle, if at the time more than 3 liter air has been aspirated, or you did a repeat chest x-ray after 2 to 4 hours, and it's still showing more than 15% pneumothorax or patient having significant symptoms. Any of these two are there, you should consider inserting a chest drain. Now look at here, secondary pneumothorax. In secondary pneumothorax, maybe it's traumatic or patient having any underlying lung disorders. Then you look if the patient is short of breath or age more than 50, or patient having rim of air in chest x-ray more than 2 centimeter or more than 15% pneumothorax. So any of these three, short of breath, age more than 50, or large pneumothorax. If it is yes, immediately you go for chest drain. Okay, you don't go for catheter aspiration, you don't go for anything else, you go for chest drain. But if it is no, but patient having a rim of air 1 to 2 centimeter or less than 15% pneumothorax, then you can just do the aspiration. If aspiration doesn't help, then you could go for chest drain. Okay, now look at our patient. 15% pneumothorax. Now it's a marginal area, right? We can say is like if something is marginal, we always think it in the next range. That means we will think it as a large pneumothorax. Okay. This patient having asthma, so it's a secondary pneumothorax. For secondary pneumothorax and it's large, okay, what do you want to do? Aspiration, chest x-ray after 24 hours, chest drain, oxygen, admit and observe. Because this is large pneumothorax, remember the criteria of secondary pneumothorax, any of these three, short of breath, A is more than 50, and rim of air in chest external more than 2 centimeter. So this patient having secondary pneumothorax, 15% pneumothorax, we go for chest drain in here. Okay. So very important to follow this format, and then you will get your diagnosis or you will get your management in this patient. See that needle aspiration and review if no significant symptom and size of the pneumothorax less than 15%. Catheter drainage or chest tube if patient is symptomatic or size of the pneumothorax is more than equal 15%. So our patient's size is more than equal 15%, so we should go for drainage. Clear, guys? Any question? And if it is tension pneumothorax, obviously you should make sure that you do the needle thoracocentesis immediately, as soon as possible. And how we know patient having tension pneumothorax? With the features of chest pain, shortness of breath, patient will also have some chest signs. That means you will find out their mediastinum is pushed to the opposite side. So trachea will be deviated away from the side or opposite to the side of pneumothorax. Mediastinum will also move to the opposite side. You can get raised JVP and you can get hemodynamically unstable patient. Next question. 30 years old patient, appendectomy done, histopathology shows 2 millimeter adenocarcinoma. What is the next step? Right hemicolectomy, no further need for any step, CT abdomen and pelvis, total colectomy. Now this is a very easy question. If it's a 30-year-old patient, you did an appendectomy, histopathology showing 2 millimeter adenocarcinoma. The management is if you get a patient having an appendectomy and you got a tumor which is less than 2 centimeter in size, okay, then just appendectomy is fine. If it is a more than 2 centimeter, then you need to do the staging by doing an abdominal CT or MRI, okay, and most of the time we go for right hemicolectomy. Now, in this case, you can see it's a 2 millimeter. That means it's obviously less than 2 centimeter. So you don't need to do anything, just observe and review the patient. So no further need for any step. Okay, clear? Okay. All right, guys. Today's class will be a little short because we just wanted to start the questions, okay, and see that how it goes. So this was exactly what I wanted to discuss up to this. And we'll stop it here tonight. Then the next class will be on 31st of August, okay? And 31st of August, we'll start our free classes, the free 2 weeks class. I would suggest all of you, if you guys still like maybe 40-60% or 50% that are you going to join the course or not, or you want to see how the classes usually are running, then this 2 weeks course will help you to find out our class pattern and everything. Okay, so I would suggest you to join the classes regularly. The schedule has already been given, Zoom ID has been given, so everything is given already. So just follow the schedule and join the class just like you have done today. I hope you guys are enjoying the sessions, and Yes, one question. Yes, it's not same. Carcinoid, adenocarcinoma are not same, but the management is pretty same. Any question for those of you who are in Facebook? All right. If you guys have any questions regarding the course, feel free to ask us. Feel free to send us message or email. We'll be happy to answer your questions. All right. Thank you all. We'll see you in our next class on 31st. No installment is allowed, Dr. Annie. Okay, because it's a very minimal amount of payment that we take, and we don't have any installment for that. Okay, so thank you everyone. We'll see you next class on 31st. Bye.